Good afternoon, everyone. I can say good afternoon because it's just turned 12. So, welcome to the Urban Transportation Center's seminar series for the spring semester. My name is P.S. Sriraj. I'm the director of the Urban Transportation Center. And this seminar series is something that we've had going on for the last 20 years that I've been here. And for this semester, we've chosen a topic that has been very, very important from multiple perspectives, and it is on health and transportation. And we have one of our own, in more ways than one. Right?
Yeah,
And one of
right.
our own from UIC, from Kappa.
Born and bred.
As he said, born and bred. So from Kappa to talk about us, before I introduce him, I'll do a little bit of a plug for the other seminars that we have planned for this semester. We have one by Melody Geraci from Active Trans, who's going to be talking about a topic that is similar to this on health and transportation, and that will be on the 19th of March. And we have on 16th of April, Erin Alleman from CMAP, still referred to her as the new executive director of CMAP. She still has within her 1 year time frame of appointment, so she's still eligible to be called the new executive director. So she's going to be coming and talking about what CMAP is doing as far as health and transportation is concerned. So put that down on your calendar. If you want us to keep you informed of these events and future events, please do sign in, and then we'll make sure you get the information ahead of time so you can plan for it. I'd also like to acknowledge that we have a TV crew here recording this event, and then this will be available on some media platform, I'm sure. It's called CAN TV, is the name of the entity that is recording this, and so thank you to them for capturing this event for posterity's sake. And now I get to the topic of today. Our speaker is Dr. Yochai Eisenberg. He's an assistant professor in the College of Applied Health Sciences at UIC. And he got his master's in urban planning from this very college. And Kurt is looking out there, and I'm very proud, as he should be, in 2008, not too long ago. And then a PhD in health policy and administration very recently. And Dr. Eisenberg focuses heavily on community mobility and access to health. Access to health is the transportation aspect. Community mobility also has a transportation aspect. So those are things that he focuses on. He does contribute to this region by being involved in various committees, and that's a long list. I'm not going to belabor you with that list, but you can find them at CMAP, at Cook County, and various other public agencies in this region. And his topic for today is mobility among people with disabilities, implications for health outcomes and access to care.
All right.
So all yours.
All right. Thank you, Siraj. And given that intro, I feel like I should do a plug about, just the idea of intersections of disciplines. And I think, we're in a time where you kind of need to be able to do that in order to address the complex problems that we're facing in our culture right now and in our society. And so I appreciate bringing me over from the west side to the east side. And even though we're geographically divided, I think we need to figure out how to work closer together and
More than geographically.
Right. And so, hopefully, be using some new terminology that'll help you become familiar with how to talk about health things. And you guys can teach me how you talk about it in the transportation world. And we can help, bridge that divide a little more. All right. So, wanted to start off, talking about how I'm a Divvy rider. I use Divvy a lot to get from the transportation to different transportation hubs, to go from east side to west side. And one of the things you learn as a Divvy rider is to stay away from buses. Buses kind of take up space, and they get real close to you, and they will go around you and push you out of the way. And so you learn that it's not good to get in front of the bus, ever. But sometimes it's worth getting in front of the bus. And I bring up this slide of the ADAPT organization, which originally stood for Americans Disabled for Accessible Public Transportation, and now stands for Americans Disabled for Attendant Programs Today. And ADAPT was one of the key organizations that put themselves in front of the bus, literally, and stopped transportation in cities like Denver, Philadelphia, Berkeley, with a campaign called We Will Ride. And they got in front of the bus to lead to policy changes, legislation changes, to make public transportation accessible, so that there could be wheelchair lifts, accessible transit stations, and more of what we have today. I bring this up because I think it's critical for us to keep in mind that transportation, and more broadly mobility, is a civil right that was fought hard for and won. And as researchers, we have certain assumptions about people and how they travel and their characteristics. And sometimes we have to put those aside and be more open to learning about people's desires and wishes and what their civil rights are. And to say that people with disabilities want the same level of mobility as people without disabilities. We see this more and more in terms of the levels of mobility and type of mobility. This is data from the 2017 National Household Travel Survey that shows, this is split up by workers and non-workers, and showing the different types of modes that people with disabilities compared to people without disabilities use. So the light blue is those who do not have a disability. The purple is people who have a travel-related disability. And so we see that the types of travel are very diverse in terms of how people with disabilities travel. And in fact, in some cases, the percentage of people with disabilities who walk is higher than those without disabilities in terms of the mode share itself. And then in terms of the local transit, that people with disabilities do use local transit at a higher percentage than people without. So does that mean that everything's good to go? We got legislation, we're good, right? Well, not exactly. This is a cartoon, political cartoon from Denver. Transportation in Denver are tricky. And it says, I'll read it for you, it says, "Quit belly aching, we're in compliance with the law as we interpret it." And so that as we interpret it part is a really key point. There were these laws, these legislations that happened throughout the last century, but the degree to which people have interpreted it and implemented it has really been all over the place. And then you see I describing a person with a wheelchair trying to get onto the bus itself. And so, we'll talk a little bit today about what are those challenges people are facing. To share some numbers, a recent Bureau of Transportation Statistics report shared that 3.6 million people with disabilities cannot leave their homes because of transportation problems. One of the main important factors to using public transportation is the pedestrian environment. So what I think you guys call the first mile, last mile, right? It'd be a good lingo usage. And that first mile, last mile is a key piece, the most important piece cited by people with physical disabilities, as well as the distance to and from transit stations, which we could think of as important for land use planning, right? Physical planning. For individuals with intellectual and cognitive disabilities, the most important was the complex and multiple transfers that occur in a system and dealing with the complicated nature of going across modes. Inadequate transportation is a problem for more than 1 in 3 people with disabilities, according to a National Council on Disability report. These issues are described for the Chicago region in a recent report that we have Metropolitan Planning Commission, Audrey Winnick, who led this report. It's called Toward Universal Mobility, and I got to come in towards the end of it. Oh, look, we got paper copies. Please take some. and that's available online as well. And it's a great report. I thought they did a really nice job. A little biased because I did come in to help with the technical committee towards the end, but they did a lot before I even showed up. So really great work about universal mobility. These are the recommendations that they developed as part of that report to address all these barriers that I described. Importance of service coordination, information and wayfinding, private sector transportation services, the Uber and Lyft, the shared mobility, upgrading technology, the first mile, last mile, the final steps of the journey, the accessibility itself of the fixed route systems, the broken and, not broken, but very segmented funding structures, and empowering people with disabilities and caregivers themselves. And so I encourage you to look at this report. Today I'm going to talk about two of these recommendations that I think my work directly relates, and some of the past research I've done and my research going forward, and I'm going to spend the rest of the talk describing those. So we'll go through how the research I'm in the Department of Disability and Human Development at UIC, how that addresses community mobility, looking at the implementation of accessible pedestrian infrastructure, ride-sharing potential and challenges, and monitoring and evaluating community mobility. And then I'll share some next steps and ideas, which I hope to get feedback and criticism and thoughts on at the end. So what is community mobility? You started to use this term. The American Occupational Therapy Association has a good definition that was also used in the Universal Mobility Report. It's that community mobility is grounded in independence, spontaneity, and identity. And the mode may change, but the meaning is the same, that transportation from one location to another enables participation in the things we want and need to do. And that participation word is one that I'll call out as a key factor. Participation means being involved, mutually participating in all different kinds of events, including employment and social settings. The definition of universal mobility that MPC came up with in their report combines the philosophy of community mobility with the tenets of universal design. It is a belief that mobility is a human right and that access to high-quality, accessible transportation is fundamental to exercising that right. And I think this is a critical piece that follows along with disability studies and disability literature. And I encourage any students here who are kind of interested in this topic of community mobility, disability, older adults to look at courses on the west side from our department. We actually hold courses on the east side, but courses related to disability studies that help describe this a little bit more. So I'm going to throw in one conceptual model here. Every talk has to have one conceptual model. And so this is a model that we use in the disability world and disability and health world. And it's called the International Classification of Functioning, Disability, and Health. Has anyone heard of this before? All right, great. And so this is a model developed by the World Health Organization to think about what disability is. In opposition to this, the model that a lot of people think of when you hear disability comes from a medical model. It's based in the idea that a disability is just you're having a spinal cord injury and being in a wheelchair. In opposition, the social model of disability that this framework is based off of views disability as an interaction between a person's impairments and function over there that you see on that side, and all these other factors, their health condition and the environmental factors, where they live, the environment around them, the transportation services that you have available to you, the assistive devices that you may or may not be able to get because Medicare doesn't pay for having a wheelchair outside of your home. And then the interaction between personal factors and how those affect essentially activity limitation and participation limitation. So community mobility would be in this participation and activity limitations that people experience as a result of this interaction between the person and environment. And I think, maybe we don't use the same lingo in urban planning, but I think a lot of what we talk about is these person-environment interactions, developing environments that meet the person's needs, wants, and desires. I threw together a interpretation of the ICF, which is really kind of in its rough framework. So just to describe how I see community mobility. So don't laugh at these sketches, or you can, but don't laugh too loud. So this is what I'm talking about. The person and an environment with a barrier essentially creates a mismatch, right? And this is what creates the disability. The living in an environment where you cannot leave your home, where you're stuck in your home because of the inaccessibility of the home, because of the inaccessibility of sidewalks, because of the inaccessibility of transportation, creates the disability, and in this case, the community mobility disability. What we're doing in urban planning and in transportation and public health is the barrier removal part. So working to improve the environment, working to improve transportation, working to improve technology to then benefit community mobility, to help people get around and participate in the things that they need to and want to. And then the goal of my research as well is to look at these outcomes, right? So how do we know if the things that we're doing for barrier removal are working? And how do we know that different options might work better than other options? And part of that is looking at the health outcomes. These are just some of them that I'm interested in terms of physical activity is an important risk factor for lots of different diseases, conditions, both physical, cognitive, as well as community participation. So getting back to that participation as an outcome, and I'll kind of bring that up throughout the talk today and try to keep you thinking about that. So I'm going to go into the 3 quick sets. It's going to be like three stories back to back about the different types of research that we're doing in our center. The first one covers the topic of the first mile, last mile by looking at the barriers that pedestrians with disabilities experience. So getting a lot of reactions from these images because these are some of the barriers that people with disabilities experience in the pedestrian right away. Again, we talked about this legislation. It went through 1990. The Americans with Disabilities Act went through, but you go and walk around pretty much any city or suburb around Chicago and then other parts of the U.S., you can start to see some of the barriers that people face to walking, to getting to and from a bus stop. These barriers have been cited as important reasons why people don't participate in healthy activities, such as being physically active, walking around your neighborhood, or shopping. Mm-hmm. And the thing is, the barriers are not going away. Right? We can't just shove them in a closet. We kind of, it seems like cities would like to forget about them, but the problem is there's several large lawsuits that are kind of pushing the opposite way. These are from the city of Sacramento, city of Seattle. There's been over 221 lawsuits through the Department of Justice. They had a project called Project Civic Access where they essentially went out to different cities in lots of different states to look at accessibility and address complaints that were filed related to the public rights of way. So we can't not think about it. Not thinking about it leads to worse and worse things. This is the Stay Puft Marshmallow Man from Ghostbusters, and if you remember, the reason he came out was that Ray was trying to not think about who the destroyer was, and this is what he thought of. I just like that part of the movie, and I also thought that this is essentially what happens when you don't address a problem. So we need a plan, right? We're urban and transportation planners. We need a plan. We need a barrier removal plan, and guess what? We are lucky because in the Americans with Disabilities Act, there was a framework for this called the Americans with Disabilities Act Transition Plan. This is something that was in the original language. And some communities did it in the 90s, some didn't. A lot of communities didn't do it for their public rights-of-way, right? So the city is in charge of managing their roadways and then all their sidewalk infrastructure, but they didn't necessarily think about addressing that in their plans. But this is a framework for doing that. The idea is that it provides you an understanding of the current conditions through doing an inventory, actually going and walking, rolling around, assessing the accessibility of the sidewalks, intersections, pedestrian facilities. It then lays out the plan for improvement, which includes how you're going to remove the barriers, your schedule, who's responsible, and involving the public through public participation. So we completed a study recently, and it is soon to be published, waiting for the final decision from the journal that we're submitting it to, and then hope to share it around. In that study, we looked at the proportion of communities in the US. We looked at a random sample of communities and looked at the proportion that have one of these barrier removal plans. And then we're also interested in thinking about what the quality of the plan was, because, right, Kurt could give many examples. If you have a plan, it doesn't necessarily mean that it's going to be used. It might go right on the shelf, right? And so we wanted to think about what was the quality of the plan to know if this is actually going to be used or if someone just put together a bunch of words. And then we wanted to look at what this tells us about the actual pedestrian environment. Is the physical environment accessible? What are they finding as part of these plans? What we found was that only 13% of our sample had a plan readily available. And of those who had a plan, only 7 of those met the basic requirements. So the level of planning is really low. The quality of the plans was also very low. Many of the plans did not meet. We developed an audit tool with an expert panel, and many of the plans did not meet these very minimal requirements and the quality measures. Additionally, what we found from the plans that were able to report their barriers, so they reported the percentage of sidewalks that were meeting the ADA requirements. We found that, on average, 48% of communities had sidewalks that were inaccessible. 65% had curb ramps that were inaccessible. So those are the ramps that go from the sidewalk to the street in an intersection or crosswalk. And then 50% of traffic signals were inaccessible, and those are related to having visual and auditory technology on them. Yeah?
Just a clarification, PROW is pedestrian right away?
Sorry, yes. Try not to use the acronyms. Pedestrian right away, yep. So some of the next steps that we're doing with that project, and that project is funded through we have a Great Lakes ADA Center that does technical assistance and training on the ADA, and that's where this particular project was from. Our next steps is that we're completing right now interviews with ADA coordinators from around the country from the areas that have had successful plans. We're trying to learn what are the successful practices, what's working to actually, 1, get a plan, 2, have a good plan, and 3, start to implement the plan. So we're trying to learn from those ones who are succeeding what they're doing right and be able to disseminate that out. We're also talking to the urban planning community about how to view this type of planning, ADA transition planning, barrier removal planning, not as a separate thing. And we've seen that in some of the kind of best practice cases that we've seen, where they've integrated an ADA transition plan with a pedestrian plan, or as part of their transportation plan. And then it's not this separate thing that may be more likely to be on the shelf, but it's something that gets integrated into their broader work. Lastly, we're starting, Amy Hofstra in the front here is a PhD student in transportation, and she is working with us. And one of the projects she's doing is developing a approach to use Google Street View, which you guys are all very familiar with, to assess the pedestrian environment, to examine changes over time in relation to these ADA transition plans. So we can start to compare communities to see how they're changing over time and what's working. This is just some slides of examples with that, where we're kind of looking at both Google Maps to identify, what the pedestrian infrastructure is itself, and then starting to look at how that infrastructure might change over time. So here we see an example of a particular corner where we can kind of clearly see a curb cut change from having no curb cut to having a curb cut. And then is another example of an area where there's no what are called detectable warnings, which are used for people who are blind to know when they're crossing the street. So their cane goes against there, and there's raised bumps that tell you that this is the part where you cross. And that's the end of the Google. Did you have a question, Heather?
Oh yeah, this is the one on the left is how like these curb cuts should be, because I love how the design is, how it's like a wide view, where that one slide previous to that, that one is pretty bad on the left.
This one here, yeah.
Yeah, that's pretty bad.
Yeah, even though there's a curb cut, what Heather is describing is that it, if you're in a wheelchair, it pushes you out right into the middle here instead of being able to go in one direction where it's more safer, right? You're going to stay
And then if you have
in the
like a certain
crosswalk.
size wheelchair, it wouldn't even fit. Like my chair probably wouldn't fit in that.
Because it's really narrow.
It's really
right there.
narrow.
Right. And this is a problem that the city of Chicago faced when they had a lawsuit in 2003, I think, where they had started building curb cuts and they were doing them wrong. And as a result, there was a large lawsuit, and ever since then there's been an effort to improve curb cuts yearly to make them become more like this way. All right. So I'm going to shift gears now to talking about ride sharing to healthcare. This is another topic that we're working on in our center and is important to thinking about in the region as well. And thinking about in healthcare, we have what's called non-emergency medical transportation, or NEMT. And NEMT is the similar to paratransit, if you're familiar, if you've seen the PACE paratransit vehicles.
Yes.
That take people around the community, but this is specific to going to healthcare visits. And then talking about the shift from that to what's called rideshare-based medical transportation, or RMT. And so there's been more and more testing of using ride-sharing. Do you guys like the word ride-sharing? Is there another term that you guys use?
Ride
Like
share.
shared mobility. I'll use ride-sharing for now. So,
Yeah, just use ride share.
thank you.
Yeah.
Good. So it's an approach that's being used for transportation to healthcare for Medicaid enrollees, right? So this is a big population of people who are low income, have disabilities, who are qualified for the service. This is a service that's guaranteed to anyone on Medicaid. And it's a service that, I won't spend too much time giving background, but it's a service that's constantly trying to figure out how to spend less money on. Even though in terms of the whole Medicaid budget, it's not really a big piece, but there's always, every state in the US is trying to figure out ways that it can cut what it spends on NEMT. One of the ways that's being introduced and started to be tested is using rideshare, so having independent drivers through Lyft, through Uber, through other services to take people to and from transportation. It's appealing in terms of the flexibility it offers, which is well suited for last-minute rides like hospital discharges. Other forms of NEMT often have to be scheduled way in advance, usually 48 hours. So if you need to use NEMT, you wouldn't be able to make an appointment till 48 hours. The rideshare-based medical transportation, right, it's more integrated with your smartphone, and so it's better able to track rides, collect data, and potentially address quality, fraud, abuse, and waste, which has also been a criticism. There's been some very bad lawsuit related to NEMT and people having a lot of fraud, transportation companies. The benefits that some of the studies have shown are that for older adults, providing ride sharing has led to less social isolation and increased reported quality of life. Another study reported a reduction in ambulance service for urgent care. And there's also been some studies that have done some modeling to look at how ride sharing saves money, right? This is the big piece that the Medicaid offices are thinking about. So some studies projected between 35 to 50% ride savings, and then $10 saved for avoiding ER trips through subsidized NEMT. There's been some criticisms about these models, and essentially they're just models. So we actually need studies that are implementing that can help tell us what's working, how it's working, and for who it's working. So in UIC, one of the programs that's been started that I think Sriraj you're involved in is called, the acronym is PRONTO, the pilot program for non-emergency transportation. And this was done essentially, I think, in the ER, right? Because there were a lot of people who weren't able to get home. And so it essentially taking up space, taking up beds in the hospital, and the transportation to get them out wasn't coming quick enough. And so by using a ride-hailing service, it helped get people home quicker, which I'm sure benefits them as well and benefits the hospital. And so they found that they were able to get a fair amount of rides per month, and set up this kind of program with a organization called Kaizen Health and Lyft. And it was paid for by the UIC hospital and now is instituted as a full program. And I think Sriraj is working with the hospital on thinking about how to scale it up. Yeah.
For various other trips that are associated with the patients as far as their follow-up healthcare issues. So it could be therapy sessions, to a grocery store to pick up medicines from the pharmacy, all the other trips that are affecting their health outcome are being looked at as possibly included in the Pronto program. That's still in the works.
Mm-hmm. Neat. Some of the challenges or issues with rideshare-based medical transportation are that there's same issues that is with Uber and Lyft, right? So there's lower pay for drivers, inadequate driver screening, and safety issues for drivers and riders. The population that's transported through NEMT is not the general population. It's people who are on Medicaid, elderly, low income, people with disabilities who have greater needs. And so there's not necessarily the driver training that's needed to meet that demand. In like the general Uber and Lyft, there's also a lack of accessibility. So lack of accessibility for people with disabilities in terms of the amount and number of wheelchair accessible vehicles and the driver training. In 2016, there was a large lawsuit from Access Living in Chicago against Uber for violation of the Americans with Disabilities Act, saying that there wasn't enough vehicles and people didn't have the same level of access. And as a result of that, I haven't read exactly too much about this, but from what I understand, the city of Chicago has helped increase the number of available vehicles that can be used that are wheelchair accessible. But I haven't seen anything about any follow-up from that. I don't know if Judy or Heather or Garland, if you're familiar with any kind of follow-up to know, is that increase working to meet the demand of people with disabilities?
I don't think there's that many, but then I don't really, because when I can use the regular Uber and I do a lot of times if I can't find an accessible Uber or Lyft, more so Uber. Okay. If I can't find an accessible one, I just get a regular one and just have them. A lot of them are friendly enough to put it in their vehicle.
Nice.
Since Heather has a fold-up wheelchair right here now,
right.
But the others, that will be a challenge to, especially for an oversized power wheelchair to get in there. That's the challenge. Power wheelchair is always a challenge to get it into Uber.
Right, exactly. So talking about a study that we did recently, we were looking to assess whether for non-emergency medical transportation, whether having more rideshare transportation to healthcare was associated with improved self-reported ride experience and less reporting of failed and late passenger pickups. And this was through a contract with the state of Idaho. Randomly, Idaho, I can't tell you exactly why, except that they saw a report we did in Illinois, they liked it, and we worked with them. And from that study, we surveyed a random sample of Medicaid enrollees in Idaho on their experiences with NEMT in the past year. We linked that data to the administrative data on the trips, right? So looking at where their utilization that was provided by both traditional NEMT and rideshare-based NEMT. And we were trying to see, are people reporting the same level of satisfaction with the ride, with the driver, and reporting less failed and late pickups. This may be a little small, but this is one of our tables from the paper that shows our logistic regression results of having basically no ride sharing, having less than half of your trips come from ride sharing, and having more than half of your trips come from a ride sharing driver. And what we're showing here is that those who had some and many rideshare based medical trips were more likely to report having a failed pickup. I don't show it here, but all the questions that we asked about the driver and the vehicle, actually there was no difference between those who had none, some, and many RMT trips. And so in some ways that's a good thing, right? It shows that shifting to ride sharing doesn't affect quality maybe. Or you could kind of look at it and say, well, that kind of shows that ride sharing is not better, it doesn't help improve quality. So if quality is really important to you, ride sharing may not be the best answer, but it does kind of maintain people's self-reported satisfaction with the rides themselves. We did see some differences between people with mobility disabilities and without, so we asked some questions about people's travel disabilities. I won't go into each of these numbers specifically, but essentially we found that for those receiving many and some RMT trips, a higher percentage agreed that they often had a failed pickup, and this was constant for people with and without mobility disabilities. Those with mobility disabilities, though, had a higher percentage who reported having a late pickup than compared to people without mobility disabilities. Yeah.
Did you define what was late, or was it left to the?
It was left to the person.
Because
yeah.
1 minute, 2 minutes late in a ride-sharing experience could be construed as late.
That's true. That's true. That's true. It might be good to kind of define that more, or think about how people interpret that question. Yeah, that's a good question. So after that study, we wanted to start doing some things around here locally. We're starting a study related to rideshare here at UIC with the Diabetes Center and Endocrinology Clinic at UI Health. And in the phase 1 of this study, what we're doing is looking to understand the characteristics of people with missed appointments. So we're trying to understand what are the people, what are their conditions, where do they live. And then we're looking to understand the role of transportation in missing appointments. So the clinic has reported that they have a very high missed appointment rate. It's like above 35%. Wow. Yeah, it's very high. And people, they know that people talk about transportation problems. They don't have it defined well enough. It hasn't been evaluated. So partly we're gathering this baseline data to understand, they say transportation is a problem. What is it? How is it a problem? What is the problem exactly? So we're doing that more qualitatively at first here through phone calls and focus groups. And then we're planning to do some waiting room assessment to learn about their interest and adoption of ride sharing. Some of the previous literature that we've looked at, some of the things that they've talked about is that even though you may offer ride sharing to a whole clinic or to a whole patient population, not everyone's going to want to use that. They may have other modes of transportation that they prefer, and they have negative perceptions about ride sharing. I think there's a fair amount of people who have negative perceptions about ride sharing, so it's not a catch-all answer. And so part of our interest is figuring out who are the people who have an interest in this, and if this would work. We're also planning to do a retrospective data analysis that gets to understanding the patient population who are missing appointments. And then our idea is to do a pilot of ride sharing, but we want it to be more targeted. And so we're doing all this kind of initial upfront qualitative work to understand, is this going to work? Which I think is a better way of doing it than saying, just going ahead and just offering the ride sharing and seeing if it's effective, because essentially it may not be effective, understanding that a lot of people, we don't know, what percentage of people necessarily may or may not adopt it. Okay, so we talked about first mile, last mile, we talked about transportation. How do we think about community mobility? That was the topic, right? So I'm going to talk about one study where we looked at evaluating and monitoring community mobility itself. And this is a study with the Shirley Ryan Ability Lab, formerly was called RIC. And in this study, what they were interested in doing is giving people with amputations a computerized device for ambulation to help them walk more in the community. And to look and understand the walking in the community and define community mobility, they gave them GPS devices and accelerometers to track the amount of walking that was done. And this is just a map showing how you can identify locations, and this is I think this is a funny graphic of their model that came from the paper. So with the GPSs and with the accelerometer, the interesting part that helps us with community mobility is that it helps tell us about the time spent at home, the time spent at community destinations, the transportation mode, and the level of recreation walking. So these are all the kind of very useful components of what community mobility is, right? Essentially people who spend a lot of time at home, if we see with the GPS devices, if there's good compliance. First of all, if there's good compliance and we see that a lot of people are staying in their home, we have a measure of community mobility showing that community mobility is very low. And then we could look at understanding the amount of walking that's done as well, understanding if it's done in the home, if it's done at community destinations, if it's done for recreation. So I'm going to show you a few different slides of what the GPS data looks like. Has anyone worked with GPS data before? Yeah?
Yeah, because you can, on the iPhone, you can track your family member.
Right, that's right. Yeah, exactly. So it's using the same technology. In this, they're not live at all, so the devices you give to people, and then we gave it to them for actually a month and collected all this data, which is collected every 10 seconds, their location. So we have a lot of points, right? And this is essentially what you get, this big glob of points. And the goal is to try to define community mobility by identifying trips, right? So visually, we can see the trips. We can see the destinations, right? Clusters of points where people stay at for a while. Problem is we do get some noise as well. GPS devices, like your phone and the GPS, when you're in a building, when you're downtown and there's lots of tall buildings, it disrupts the GPS signal, and so you get noise as well. We developed a methodology to clean the data using GIS, using a tool called kernel density with the speed to differentiate trips and destinations. And this map just shows kind of the output of a model we created. All the green is trips, and the red are the destinations. And the result of the model is we actually get the defined destinations here, these polygons that help define a place that a person stayed at for more than 5 minutes. And it's not enough necessarily to say that someone has a lot of destinations. Our interest was also knowing what types of destinations there are, because if people are spending all their time in medical facilities, is that really community mobility, right? I mean, people may be, and that's, I guess, an interesting case, but people may need those appointments, right? But there may be things that we can do to help people in spending less time in medical appointments, in healthcare, and being able to spend more time in community settings. If we see that a person is only going to the doctor and back, is that really participation, right? Which is one of the key aspects of community mobility. So from this, we're able to develop essentially a digital trip diary, right? Which defines destinations, home, travel, and the types of destinations. This is kind of showing how we marked out one person's day, going to the grocery store, a shopping center, a convenience store. And we've developed ways to also code as different modes, right? So a walking mode versus a public transportation mode versus a driving mode. And so, the result is we get data, right? A big data table that tells us every single movement from a destination to a trip, back home, and et cetera. And I'm going to go through some of these slides quick because I wanted to leave some time for questions. But to help capture these, we used land use data from CMAP, as well as some Google Street View coding in ArcGIS to label destinations in terms of the type of land use. And these are just some graphs showing for one individual what the Shirley Riderability Lab was interested in is, does this device work, right? So they compared the device to other devices, non-computerized devices that a person would use. And this is just one of the outcomes that I showed you, the time spent in the home. And we can see some differentiation there. The time spent out of the home, is related to demographics. So this is another outcome that we could start to think about, looking at what factors are related to time outside the home. So in this study, people who have wheelchairs had less time outside the home. African American, living with someone else, more time outside the home, right? And that's another important aspect of understanding the person's context, is whether they live with someone else, have a caregiver, things like that. And then this graph shows the types of places that they went to. So we're able to kind of differentiate by device. What's the what is the the mix of places that people go to. We want to see a high mix, right? We don't want to just see home and medical. And this, by looking at the types, we can start to do that. The end result of that study, I was just going to show you quickly because finally they're working on publishing the paper. They actually were able to find out against what they wanted, that having this computerized device, they spent the same amount of time walking both in the home and walking in the community. And this helped show some interesting aspects about what people prefer and what people actually use outside the lab. So this is a way of kind of understanding how technology, in this case for people with amputations, is actually used in the community. Any questions on that study or any of the other studies so far?
So what's the blue and what's the orange?
Yeah, sorry. Gosh, I don't have a legend up here, do I? What is the blue and the orange? So, oh yes, the blue and the orange. So one is the blue is the person's original device, so it's a non-computerized device, and the orange was a computerized device.
Okay.
Yeah, and these these are called box plots, and they basically, their overlap shows that there wasn't a difference between the two devices. So thank you for asking that. I realized I did not have the legend up there. So let me just run through some next steps and ideas real quick, and then we'll have some time for questions. So again, I'm kind of interested in looking forward and new ideas for studies. One of the things I'm interested in doing is working with the soon-to-be-released CMAP Household Travel Survey. So this is data that is scheduled to come out in March and April. And as a university, we can set up a data sharing agreement to get origins and destinations of people who took this survey. They reported more than 12,000 people who took this survey. And a great thing about this version is that they asked about disability for the first time. And so we're able to learn about people with disabilities travel patterns in the Chicago region, both about rideshare use and walking trips. The walking trips is important in terms of kind of understanding the physical activity outdoors. And the things that I'm interested in are looking at what are the environments that people are traveling to. So not just, how many destinations do you have, but what is the environment around you and the environment around where you go to help understand that first mile, last mile, right? Because if we see that we can start to understand, what is the pedestrian environment around where people live, and is that leading to less mobility than people who live in areas where they can get around, where the accessibility is higher. The Google Street View takes a long time, and so we are trying to work with some other folks nationally who are doing some work to computer scientists to use machine learning to code the Google Street View images, because it does, as Amy is learning, takes a long time. We're also doing some analysis of the NHTS, the 2017 study, to look at ride sharing among people with disabilities. This is a pretty newer data set, and we're interested in looking at relationships between ride sharing and participation. So for people who use ride sharing, does that help improve their participation, their community mobility in the places that they go to in using the NHTS data? And then the last slide I just wanted to talk about is, we have this great universal mobility report that I started off with, and I think it's a real kind of call to action for the region. There's, I think, a lot of stuff that is going to happen from that report. But I think it's important that we think about how to evaluate universal mobility. How do we evaluate community mobility to know what's working, right? To know what's being implemented, and to see if the ultimate outcome, right, of community mobility is getting better. The CMAP data that I mentioned a few slides ago essentially provides a baseline, right? It was taken last year, I think. Provides a baseline. They're going to do it again in 10 years. It'd be great to figure out what kind of outcomes that data set, there's, I'm sure, other data sets maybe that you guys can think of to help in thinking about how can community mobility improve based on some different interventions, different projects that we can start to test out. So that's it. I got 6 minutes for questions and discussion. And thank you for your attention. Appreciate it. Yes, Judy.
Excellent. Thank you for your work. Do you think that we'll ever move beyond measuring mobility in terms of just whether people can get to a job or get to healthcare? Do you ever feel like we could help the field figure out how to truly collect outcomes, the impact upon health, the economic contributions of an individual, the education, that kind of thing?
I think it's getting to that in the way that data has become so available now, and the ability to link other data sets to these mobility data that we have that's existing. So I'm thinking of, for the health-related side, it's linking electronic health records. There's more and more you're able to do that. It gets harder in some ways, but it's becoming easier, partly because the technology for anonymizing the data is better, even when you're linking. So maybe in the future, we'd be able to link the NHTS data or CMAPS data to someone's electronic health records to know if something has improved. Or, in terms of the economic data, I'm not sure, what that data set is. But I think the administrative linking of data sets is becoming more and more prevalent, and there's funding for that, for researchers to do that. So yeah, I think that's something that you can do with other health surveys, like the National Health Interview Survey. There's ways of linking that to electronic health records. So I think it will, there's with that, right? There's people who object strongly to it in terms of, you're seeing my data, oh no. But I think there's a lot of benefit, and the level of privacy that people who work with the data take is really strong.
It really creates the ROI though for all of this.
Sure.
Why should
Right.
transit providers invest? Why should
Yeah.
federal governments
Yeah.
invest in this if we could demonstrate true outcome?
Right, exactly. Right, because and some of those are the ones who would fund a ride sharing, right, or fund other types of interventions that would help change the transportation and physical environment. Yeah. Or Heather,
yes,
you had a question?
Yes, was it the reason why both Seattle and San Francisco got lawsuits? Is it because they were extremely hilly and you cannot walk? I've been to Seattle and I know that that's very hilly.
It is. I don't think that was the reason. I think it was the actual physical infrastructure. The sidewalks were not accessible. When you have a hilly area, essentially under the ADA, it's not considered inaccessible just because it's hilly. You can't change the hill, right? But you can change the connections to that sidewalk. You can change, other options for routes that people could take, use of elevators, things like that.
Okay.
Yeah, good question though. Thank you. Does Sriraj have a question, or
No, I don't.
Kurt? Do you have a? Yeah.
Yeah, I found it really interesting, the ride-sharing data and the whole area of research.
Thanks.
It made me think about the supply of ride-sharing vehicles that are accessible, though. I'm wondering how much research there has been looking at where they come from, what creates a tipping point where somebody's willing to go from maybe a minimally accessible vehicle to a more greater accessible vehicle to families who have somebody with a disability. Is it entrepreneurs? I'm just wondering if there's been much research.
I don't think there has. I haven't seen too much. I mean, it's very new, right? Like this lawsuit in Chicago, it was 2016, and I think there's been some developments, but I haven't seen too. I don't know if Judy or Susan, if you're familiar with any. There's been some funding from the FTA for kind of like pilot projects to look at that.
And actually, those evaluation findings are just coming out.
They're just coming out. Okay.
The mobility on.
And are some of them related to the ride-sharing vehicles?
Yeah.
Okay.
Yeah, transit agencies have entered partnerships with
Great.
various providers. People with disabilities been included. One of the proxies for the numbers of ride share that typically is wait times.
Okay.
Presumably, if you have less wait time, that means you have a sufficient number of rideshare vehicle, wheelchair accessible vehicles for the numbers of riders that need it, and so wait times would be okay. So that's in the Chicago agreement that they have. That's a measure.
Okay.
Is the wait time.
Interesting. Yeah.
Has there been a consideration of integrating what's good about rideshare in terms of the ability to get things on demand and not have to wait 2 days into currently existing public goods, whether it be transportation, almost a public option for these things, so you're not just farming everything out to these
private
kind of problematic companies sometimes like Uber as a way to include it into our current public transportation.
There are some models out there in some cities that have taken a real partnership, I think, and have based it on thinking about taking part of their public transportation funding and using that, where I feel like I heard of one city that like their whole transportation budget they put to having ride sharing. I can't remember what it was exactly, but
Well,
maybe
I
you
don't
guys
know
have some
about the whole
examples.
city putting their transportation budget, but,
I think it was in Canada, maybe.
is, a really good example of creating partnerships with the community, and it came out of, you know, a crisis, but they've done really well with their Rise to Wellness program, and it's continuing to expand. It's looked at on a national level,
Nice.
spotlighted a lot.
Nice, right.
They're extending that to veterans.
They actually established their own vehicles, so instead of contracting with an Uber and Lyft, Flynn decided that instead of having, you know, 60-foot buses or even like a paratransit-sized vehicle, that they are using cars. They're- yeah, well, in Detroit, they have the whole AV Smart City Challenge thing going on, so.
Interesting. Yeah. Okay.
The problem is that when you have like those like Dodge Caravans for like ride share,
Oh yeah.
and the problem is you can't get most. You could get some wheelchairs in there, but most wheelchairs couldn't fit in there because those Dodge Caravans are designed for kids. Whereas if you had the Ford Transit, because I saw one of those at the auto show,
Huh.
and the good thing about the Ford Transits, they're designed for like people like myself and large most wheelchairs. Those are like the ones that are like almost like one size fits all.
Gotcha.
You get those Dodge Caravans, and most people couldn't fit in them.
Yeah. Yeah. So maybe, you know, understanding the quality of the wheelchair accessible vehicles is important, and you know, I to your point, Kurt, I think they like understanding that from the driver's perspective is important too, right? Because they're essentially the entrepreneur in potentially taking on a wheelchair accessible vehicle, and so it'd be important to evaluate. I'm not sure if they're doing it in Chicago. How, you know, is it working for drivers? Are you having a lot of turnover for the ones who are driving the wheelchair accessible vehicles, or is it like high demand to have one of those because you're constantly working?
We are 3 minutes over, but because Brian has been so patient, we'll entertain this question and then cut it around.
Thank you.
Great.
So my question is about the transition plans. Of the 54 that you analyzed, how many of those were created independently by the community, and how many use a subcontractor or some kind of consultant to create those transition plans?
Yeah, I don't know the exact percentage, but there was a fair amount that had used consultants. Yeah, but I could, if you want to give me your card, I could follow up to look at that. That is one thing we tracked. And you know, it's in our interviews that we're doing right now, it's something that we're asking about. Some of the communities had those, and it is a really good way to help get a jump on collecting the data and starting your plan, but a lot of communities don't have the money for it because it really costs a lot. So we're also trying to learn and interview the communities that don't have the money and finding their own staff and ways to do it. Yeah.
Thank you.
All right, thank you, Sir Ryan. You guys made it. You listened to the whole hour.
And thanks to you all for being very engaged until the last second, and then thanks to CAN TV for recording the proceedings.
Yeah.
And the next seminar will be on March 19th. So put it on your calendar. We'll see you again in a month.
You know where Chick-fil-A is.
Thank you all.
Chicago,